more topics than I thought we were going to accumulate by now to discuss. And for people who think the government doesn't get much done, I don't think we're going to solve anything today. So we'll make them feel good about this. But we're going to begin to address some very important topics that are almost everyone is going to require follow-up, I think. We're going to be, just to get the menu clear, and then we'll just kick it off. We're going to talk about the topic of competency restoration. These are individuals who commit a crime and who are deemed unable to participate in their own defense. And it's a real problem and a real mess. We're going to get kind of a report on the updates on the FMAP money that we spent so much of, and there's a couple of snags there we're going to have to talk about. We'll talk about child care stabilization grants. We're going to talk about how to get individuals back into day services who are medically not able to take a vaccine if the center is going to require vaccines. And then we're going to talk about the Biden nursing home vaccine requirements that are, at least at the very least, very interesting. So anyway, with that, I want to welcome everybody. And if you read all of this stuff here, good for you. On the competency restoration, there is a ton of information. There's been a task force. The issue really is about what happens to a person who is unable to participate in their own defense. And now we're not even charging them with misdemeanors. And if they're well enough not to require hospital level care, they are pretty much drifting around. Some are in jail, some are on their own home, some are homeless. And it really presents, in my mind, a public health risk, a public safety risk, but as well as concerns for the individuals. So we're going to try to work through that for a while. If we could somehow finish this topic in 45 minutes, that would be nice. I don't know if it's possible, but we will certainly be revisiting to this. We've invited some of the public safety members, Senators Limmer, Bigham, Latz, and Matthews have been invited. I don't know if they're here. If they are, they're certainly willing to participate in the discussion as well. So with that, I'll just start off with Dr. Stevens from DHS. We were unable to get a person from the court to talk about this, just to help us with the background. And so the point of today is to crack open the lid on this topic, which is squarely, at least partly, in our turf and a very real concern. I understand there's 672 or so such individuals drifting in Minnesota doing whatever, and they're on their own recognizance about getting themselves competent. So without taking away any of your thunder, Dr. Stevens, welcome to the committee. I appreciate you being here.
Thank you so much, Mr. Chair, members of the committee. I want to thank you today for the invitation to come speak on behalf of Department of Human Services. I need to just check on my screens here, and I apologize for the delay. Okay. My name is Dr. Kylian Stevens. As Senator Adler noted, I'm the Executive Medical Director for Behavioral Health for Direct Care and Treatment. Also joining me today in the hearing is Deputy Commissioner Chuck Johnson, who might be able to answer some questions as well. I'm a forensic psychiatrist by training, so this is my area of expertise and certainly interest. Next slide. Before we move on today, we thought that it would be helpful to talk a little bit about DHS and our treatment services. Just as it's not always completely familiar to everyone what we actually do within direct care and treatment. Direct care and treatment, or DCT, it's a highly specialized behavioral health care system that serves patients whose conditions are so complex or challenging that other health systems cannot or will not take care of them. Nearly all of the people we serve have been civilly committed by a court as individuals who are mentally ill, chemically dependent, developmentally disabled, mentally ill and dangerous, or as sex offenders. Last year, about 12,000 people received services in DCT's treatment facilities, residential and community-based settings. From a personnel standpoint, we're the largest division at DHS, the state's largest agency. Still, DCT's annual budget accounts for just 3% of the agency's overall budget. And as a healthcare system, DCT is about the same size as Centricare, for reference. DHS provides mental health treatment that is not available anywhere else in Minnesota, but our inpatient treatment capacity for adults with mental illnesses is limited, as you may have heard. Currently, DHS is budgeted to operate 576 beds spread across 8 facilities statewide. That total includes 110 beds at Anoka Metro Regional Treatment Center, or AMRTC, 370 beds at Forensic Services, which many of you know as the Minnesota Security Hospital, and 96 beds at the 6 community behavioral health hospitals in Alexandria, Annandale, Baxter, Bemidji, Fergus Falls, and Rochester. As Senator Adler introduced, people who have been charged with crimes, found incompetent to stand trial, and civilly committed are involved in a fragmented system where the players have distinct and often conflicting roles. Criminal and civil courts must rule on competency and civil commitment. They often want defendants who might be restored to competence kept somewhere secure. Counties are responsible for supervision of people in the community under commitment, which can be challenging, certainly. Sheriffs cannot hold incompetent defendants indefinitely in jail. Their interests typically are in public safety and obtaining a DHS beds for those who are ordered into treatment. County attorneys have 2 roles, one as a prosecutor interested in successful prosecution of a case, and are also responsible for filing for civil commitment for incompetent defendants. Their interest is often in maintaining a secure placement for an incompetent defendant. And finally, DHS's role is to provide mental health treatment. We are a healthcare system, not an agent of the other parties. We work in partnership with them, but the roles are distinctly different. Most states, 47 in fact, have legislative enactments authorizing the criminal court to order competency restoration and mental health treatment after a finding of incompetence. In Minnesota, competency is dealt with in a court rule of criminal procedure, which is referred to as Rule 20. Court rules apply to judges, parties, and proceedings in a case. There's also a statute prohibiting prosecution of a defendant who does not understand the proceedings or cannot participate in their defense due to a mental illness or cognitive impairment. But no statute says what happens next, only the court rule does that. If found incompetent, a defendant must not plead, must not be tried, and may not be sentenced. If found incompetent under Rule 20, misdemeanors are dismissed and other charges are suspended or paused, if you will. The court then refers the defendant to the county pre-petition screening agency and the county attorney for possible civil commitment. Pre-petition screening must send a written report to the county attorney within 5 days with a recommendation about civil commitment. The county attorney then decides whether or not to seek civil commitment. The standards for civil commitment and competency to stand trial are very different. Civil commitment has a higher bar to meet than competency. So there are situations in which someone may be incompetent to stand trial, yet not meet criteria for civil commitment. These are sometimes called gap cases. To be civilly committed, an individual must pose a substantial likelihood of harm to themselves or others due to mental illness, organic disorder of the brain, or intellectual or developmental disability. They must have made a recent threat or attempt of physical harm or have failed to obtain necessary food, shelter, or care. The goal of civil commitment is not detention. It is to provide people with mental health care and treatment, which will make further supervision unnecessary. The goal is recovery. In looking at the scope of this population, you might be surprised to hear that between 2010 and 2014, only 34% of incompetent defendants were subsequently civilly committed. For the remaining 66% of individuals, either no treatment petition was filed, or if filed, the civil court did not commit the individual. So what does competency restoration entail? There are really 2 key components that I like to break down in this way. The first is mental health treatment using medication and other interventions that focus on reducing mental health symptoms and stabilizing a person's illness if present. Secondly, there's an educational component, which helps defendants assist in their own defense and prepare them for criminal court. Preparing the person for prosecution is the only goal of competency restoration. It is important to remember that incompetency is not a mental illness, and competency restoration is not just mental health treatment. The goal of treatment is stabilizing a person's mental health condition with a focus on recovery. This is provided by qualified doctors, nurses, and other highly trained clinicians. The goal of competency education, on the other hand, is to help people understand the charges and penalties they face, work with their attorneys to aid in their own defense, and behave appropriately in court. Teaching competency materials requires no specific expertise and can be provided in most any setting by an adult who can follow a teaching guide and curriculum. No law in Minnesota requires DHS or any entity to provide competency restoration, nor any defendant to undergo it. Just like the law doesn't require provision of competency treatment, it does not tie provisional discharge to competency attainment. Instead, the law gives the head of the treatment facility discretion over provisional discharge. This means there's no judicial review of provisional discharge for most commitment types. Neither the Commitment Act, the Criminal Code, nor Rule 20 authorizes court review of the decision to provisionally discharge a committed person. In the past, DHS did factor competency into discharge decisions. This was not required. We did this because we had some limited capacity to offer a supplementary service to accommodate judges and county attorneys who expected state-operated facilities to hold individuals until they were competent to stand trial on previous charges. As a result, many beds in DHS facilities were filled by people who didn't need them. The focus on competency had become a significant barrier to discharge. At the same time, demand for admission to DHS facilities rose dramatically, driven by the state's 48-hour law, which requires DHS to prioritize admission to certain individuals from jails. In July 2013, Minnesota statute was amended to require DHS to prioritize admissions of certain individuals from jails within 48 hours. By far, most of these are individuals who have been found incompetent to stand trial. You can see here how rapidly admissions from jails rose in just a very short period of time, from just 44 the year the 48-hour rule was enacted to a peak at 2018 of 288. As a result, patients in community hospitals waited for weeks or months for admission to state mental health facilities, effectively cutting off access to state-run facilities for everyone else in Minnesota. So the only way to treat more patients with the same number of beds is to discharge those who no longer need hospitalization. We faced and continue to face intense pressure from law enforcement, counties, courts, emergency rooms, and advocates to admit and treat more patients. Who are we talking about? These are people who are psychiatrically stable, but not necessarily competent to stand trial on those previous criminal charges. These individuals do not need to be hospitalized, but they take up a great number of beds at DHS facilities. To free up treatment capacity, in 2018, DHS decided that competency to stand trial was no longer a factor in provisionally discharging patients from DHS-operated mental health facilities. While in our care, however, people receive appropriate treatment for their mental illnesses as long as it takes to stabilize them. During that time, patients also receive competency education. So they receive those services while they're with us and under a Rule 20 status currently. However, once patients are psychiatrically stable and no longer require inpatient treatment, DHS provisionally discharges them to an appropriate setting arranged by county case managers, even if the patients aren't yet competent to stand trial. DHS does not continue that competency education after they leave our care. The decision to provisionally discharge is a clinical decision made by treating clinicians in collaboration with county partners, treatment providers in the community, and the patient themselves. Common provisional discharge requirements include things like attending appointments with community treatment providers, taking prescribed medications, refraining from using illicit substances, maintaining contact with their county case manager, and the like. This process has not changed and continues in this way today. Once provisionally discharged from a DHS treatment facility, patients are no longer in the custody of DHS. We have no authority under law to monitor individuals committed as mentally ill, chemically dependent, or developmentally disabled who are on a provisional discharge. That authority and responsibility is granted solely to the supervising county. So what happened as a result of our change in 2018? As expected, changing the provisional discharge standards has allowed DHS to admit and treat far more patients, nearly 44%, who needed hospitalization at the AMRTC facility, which is by far our state's largest psychiatric hospital. Average length of stay has also been reduced, signifying that patients are stabilized more quickly and we are serving more people as intended. In closing, everyone recognizes that this is a shared problem, and the question of how to handle competency cases needs a thoughtful solution that works. We all agree this problem won't be solved without attention and direction from the legislature. I think we have a unique opportunity to design a system that works for Minnesota and can learn from the experiences of other states, some of which work well, others don't. In the end, the best solution may be to create several options for competency restoration that include inpatient settings when appropriate, jails, other community-based settings, or even a defendant's own home. No matter who the legislature designates as a responsible party or parties, lawmakers also need to establish a framework for delivering services, a system of governance or oversight, the necessary infrastructure, and an appropriate level of funding to provide the services on an ongoing basis. Thank you for your time.
Well, thank you. That was very helpful, and I actually learned quite a bit there. So we have three testifiers. Does anybody have a burning question for Dr. Stevens? I'd rather hold most questions to the end, but we're not that rigid here. So, and if I don't see your hand, just shout out. All right, did anybody want to? Okay, I didn't see any hands. Although my screen is limited. And so, Brittany, if I missed somebody, just send me a text. Well, why don't we move on to Ms. Abderholden then? And then we have Michelle Simpson after that, who lost a daughter to one of these clients. Anyway, so Ms. Abderholden, welcome to the committee, and I appreciate what you do. And you also chaired the task force, which, clearly, there was a lot of content as you discussed it, and you had quite an army of people. So tell us about that, and welcome to Interim.
Thank you, Mr. Chairman, members. Sue Abderholden, Executive Director of NAMI, Minnesota. So between 1999 and 2014, states who were responding to a survey saw an average of a 72% increase in the number of people receiving competency restoration services in state hospitals. And what we saw across the country, so this is not just a Minnesota issue, is that we were using scarce resources, mainly state hospital beds, for evaluation and competency, which caused, frankly, backups in the jails where people waited long hours or long periods of time for competency restoration. But it also led to most of the state hospital beds being used just for people coming from jails, just for this issue. And what we saw is a couple of things. One is that people in the community couldn't get hospital level of care and then sometimes ended up in the jail, right? Because they weren't getting their symptoms treated. But also when people were waiting long periods of time in the jail, it led to lawsuits. Probably the most well-known is the True Blood versus Washington State Department of Social and Health Services. And the statewide, and why NAMI and others became concerned about this is, as you heard, Anoka Regional Treatment Center was really being backed up because it was mainly taking people who were deemed incompetent to stand trial from the jails. And this created a flow issue. What we can tell you is that families were even told after the 48-hour law was passed, is if they wanted to get their loved one into Anoka, to actually get them arrested. And that was going to be the only way that they could get into that level of care, which of course is not what we want to see. And so what we did is we were just kind of worried about all of this, right? And of course there was the department changed, and we thought, well, if people get the mental health treatment and they don't need that level of care, but they're deemed incompetent, they often go back to jail where then they can decompensate again. So it was kind of a mess. And so we had originally actually gone to the National Council on State Governments to see if we could get some technical assistance from them. And we had formed a group with Mental Health Minnesota and the Mental Health Legislative Network. And we put together legislation based on how we could actually get their technical assistance. In the end, we discovered we could get a grant through them. And so we just kind of pushed forward with state legislation carried by Senator Sen John and Representative Bonner. And really what we wanted to do was to look at, how does Minnesota and other states provide competency restoration programs, and what are the recommendations that we can do to address this issue? Next slide. I think what's really important here is that the duties of this task force were multiple. We wanted to identify current services and resources. We wanted to know what the trends were by counties, and that looked at counties that had diversion efforts. We did do some case reviews. We definitely researched other states using all the resources we had. And then the recommendations were going to be in 3 areas. 1, looking at prevention and diversion. 2, the timely process in the justice system. And 3, provide and fund community competency restoration. One of the things that we wanted to look at initially is, why was this increase, right? Why all of a sudden did we have so many more people who needed competency restoration? And we looked at what other states were looking at too. Some of the reasons, that were thought of were things like, well, maybe there's an increase in prevalence rates of mental illness. Maybe there's increased potency and use of substance use disorder or substance uses, right? People refusing to seek treatment voluntarily or not being able to do that. We thought there were many, many different issues. And that's why we actually looked at what are the poverty rates in certain counties, what are the opioid overdoses. We tried to look at all of that to see if it all was connected. And honestly, we couldn't connect all the dots. One thing we do know is that, back in 2007, Minnesota required jails to do screening of mental health, a mental health screen for anyone entering the jail. So there was more awareness there. We did hear from, attorneys and judges that they were more aware of mental illnesses. So all of this could have actually led to that. Next slide. One of the things we had was a big committee, and William Ward, our state public defender, was the vice chair, but we knew we needed everyone at the table, because there was no one system that was responsible for this, right? There were just many, many factors in leading to this problem, and everyone was going to need to be involved to be part of the solution. And so we really had, I think, a good group of stakeholders, and we had, very thoughtful discussions. We had different presentations. Everyone was really involved. And one thing we really, came to know is that this was a complex problem, and there was no simple solution, honestly, that it was going to take several different things. When we looked at who is incompetent to stand trial, we kind of saw it in a couple of different areas. So when we saw people who maybe short-term could be quickly restored just with a little help, they didn't necessarily have an acute mental illness. We had other folks who really needed maybe a longer term of treatment and more intensive services. Then there were folks who even needed longer than that. And then there were some people who would never be restored to competency due to perhaps it was an intellectual disability, or a brain injury or something like that, dementia, and we needed to think about them differently as well. Next slide. So our findings when we looked at prevention and diversion is we all agree that the best way to deal with this is to divert people from the legal system in the first place. And so we can't just separate the two, right? So one of the things we looked at is, so how can we build our mental health system, continue to build it, needing to look a little bit about systemic racism, because we looked at the disproportionality, and then other things, it wasn't just that someone had a mental illness. They also sometimes had lack of housing. They didn't have healthcare. They didn't have their basic needs met at all. So in trying to kind of narrow down our recommendations on this issue, one of the issues, of course, is to fund a continuum. We actually pretty much know what works, right? I mean, we know the different levels of care that works in Minnesota. We just haven't, in some ways, fully funded it. We know that our crisis teams can be an important part in diversion. One of the issues, as you know, is that no one knows those crisis numbers. So the law that passed this last session, Travis's law, and looking at the 9/11 telecommunicator working group will also help us kind of move forward in that direction. So no matter what number people call, they can get the actual proper response. You might remember that 2 years ago, we passed a kind of a redo of the Commitment Act. One of the things we included in there was voluntary engagement services, so that we don't have to wait till someone becomes a danger to themselves, but that we can provide some innovation, kind of interventions and supports. So as soon as someone, particularly family members, they know someone is decompensating or they're seeing psychosis for the first time, they don't have to wait for commitment. They can ask for voluntary engagement, and we can have someone go out there for up to 90 days to really try to engage that person into treatment. And we know that people who do engagement services, like some of our homeless outreach services, do a really good job. This, of course, was voluntary. And we actually have been promoting to the department and frankly to you that some of those federal dollars could be used to try to pilot voluntary engagement to see how it works and to see if, in fact, we can prevent this from happening. One of the things we know, not here in Minnesota, just not in Minnesota, but across the country, is that housing was a huge reason. Up in the St. Cloud area, when they looked at people who are frequent utilizers of both jail and ERs, they found that unstable housing was kind of a common theme. We also know that we have a workforce shortage, a huge one. We did, address some of that last session, but we can't sit there and say we're going to continue to build our mental health system, but we don't have people to do the work. And then lastly, we wanted to make sure that we looked at some of the diversion programs, such as the Yellow Line program and things like that, where we are kind of catching people early and diverting them from the criminal justice system altogether. Next slide. The next finding is we looked at, so how do people go through the legal system? What kinds of things can we do there? And we certainly saw that court officials need some training, frankly, around mental illnesses and the local mental health system. Often people think, if they're not familiar with the mental health system, that the only option is ANOCA, or the only option is inpatient hospitalization, when there are actually lots of other resources available that could be appropriate for people. Remember, just even with the 48-hour law, we're not allowed to do an assessment of what level of care that person needs. They just automatically go to ANOCA. We saw that the judicial branch, which is why they created their task force, which I was a part of as well, is that they were worried about the money that was being spent on forensic exams. So we're spending all these monies on evaluations, but not necessarily services. They also saw that the exams, the competency exams varied greatly from district to district. There was kind of an over-reliance on civil commitment, thinking, well, we're just going to try to commit everyone, but it's a different court, right? It's often a different judge who's doing the competency versus the judge who's doing the commitment, and not a great understanding necessarily there. A lack of support and supervision in the community, which really leads to the revolving door. So there isn't any one, intensive case management or something like that happening. And then again, we don't have a rule or statute that requires defendants to participate in restoration services or requires anyone to actually provide it. Next slide. So some of the recommendations included, so let's have some minimum mental health training and continuing education requirements in this area for judicial officials. We need to fund mental health care in the jails a little bit more. When we talk about the 48-hour law, you have to remember that someone has already been in jail for several months. So what are we doing during those several months to make sure that people are accessing effective treatment? The bill that passed last session in terms of jail oversight, we think will help, but we need to actually, support mental health services being provided in the jail. There are some pilots that we could be funding to see if we can expedite the competency process, same-day evaluations, pre-screening, so people aren't sitting in the jails while, honestly, they can't even access Medicaid to pay for the treatment that they need. Looking at video technology, if you look up in Carleton County, they do telehealth in the jails. So when the Community Mental Health Center has a no-show, they can immediately contact the jail and get someone involved right away. And then really looking at not only expanding mental health courts, but also can we create restorative and competency courts? So we have people who are very knowledgeable about the system, who kind of know the people who are coming through, and that might free up some time and resources as well. And then the last area was the Competency Restoration Continuum. And again, this is going around the state. So I was actually part of the Council of State Governments National Task Force that convened back in 2020. And so I was really able to hear about what other states were doing. And honestly, no one has a good solution yet. Everyone is still trying to figure out what are the different things that we can do. Some of the states have a less developed mental health system than Minnesota. And then we have some other states that, they're pretty similar to us, but are still struggling with what to do. Even states that are under a court order, like Washington, are still struggling with actually what to do. Our task force, of course, we really wanted to look at, so what's happening in Minnesota and looking at some case data as well. Next slide. So one of the things we wanted to do was to really create a statute that really governed competency, really address the gap cases, and really address if people are never going to attain competency, why are we spending all this money on evaluations? That's not a good use of our resources. We thought about developing a standard, flexible statewide competency restoration curriculum that people could use across the state. Also funding a continuum of where the services could be held. And I think this is important. If someone's in an inpatient hospital, can we help a hospital actually provide the competency restoration services there so there's no need to go to anywhere else? Can we also look at community-based services? Frankly, IRFs facilities, which we had one many years ago. And one of the things you can do is you can actually have a locked IRFs facility. So one of the reasons judges don't think about IRFs is because they're generally unlocked. But if we're looking at specific services so people don't have to be in the jail to get those services, right? We can provide more intensive services. This might be a way to go. In talking to the provider who had done this, they said, you have to remember, we can't do a 16 bed. You can't have 16 people, right, who all have been involved in the criminal justice system right now in one place. So we would need to make it smaller and make sure that we can fund it that way. We also need to look at jail-based. Again, even if someone is looked at in terms of, starting incompetency process, they're still in the jail for a while. Well, can we start that education right away? And then the last idea, which I really hope that we can move forward, is having certified forensic navigators. So this would be someone who is knowledgeable about both kind of the human services, mental health system, and the criminal justice system. So they would really be following that person into the community so that person is not getting lost like they kind of are now, and making sure that they're following up with treatment, that they're getting housing, all the other kind of factors that can contribute to someone, especially with a serious mental illness, ending up in the criminal justice system. One thing I do want to mention is when we talk about, kind of who ends up in there, a large percentage in a national study found that it was actually people with psychosis, people with schizophrenia. And, Senator Abel, I've been before your committee several times about the importance of the first episode of psychosis programs so we can intervene early, right, and really get people on the right road to treatment and recovery. And so that those people in particular don't end up, frankly, in our criminal justice system or in our homeless system. Now, legislators who know me know that I won't sit on a task force if all it's going to do is that report sits on the shelf. And so we have been working first with a small group and now with anyone else who wanted to participate in actually developing legislation for next session that will carry out some of these recommendations. And I would like Elliot Bhutai from my staff to just briefly talk about where we are with that legislation. Elliot?
Welcome to the committee.
Thank you, Mr. Chair. My name is Elliot Bhutai. I'm the Criminal Justice Coordinator at NAMI, Minnesota, and worked closely with the task force and on the drafting this proposal. And one thing that we value at NAMI is having consensus. So we brought everyone back together to make sure that we could, meet everyone's needs. But probably, as Sue said, one of the biggest things that's in the bill is establishing these forensic navigator positions. So they would be certified through DHS. We also want them to be flexible so that it's not, it doesn't have to be a mental health professional, you know, peer support specialists, people, we want to use our resources well. And so, but really, I think the biggest thing is that the legislation, when somebody's competency is questioned, then a forensic navigator is immediately assigned to that person. And then they're basically just to fill that gap of supervision and to follow them through the court, to act as a liaison. So reporting to the court, communicating where we've seen that sometimes the communication has not happened. This position is to do that. And then another important part is that when charges are dismissed, the legislation still dismisses misdemeanors because the majority of those are something that doesn't need to be addressed in the criminal justice system largely, is that they'll have dismissal plans. So it's not just sending somebody out and saying your charges are dismissed. It's having the forensic navigator work with them to say, do you have housing? Where are you going? Can we set you up with, you know, appointments and get you the resources you need before you go back to the community? And then also allowing them to continue engaging people after their charges are dismissed for up to 30 days. So wanting to really make sure that people aren't going through that revolving door. You know, doing this in statute is to address the issues with the rule that nobody is responsible. So this is just to say, and to give authority to the court to order people into competency restoration treatment, which is not civil commitment, but because it's a continuum, we intend to have no gaps there. So if people need inpatient hospitalization, then we intend to have flexible, you know, certification processes for hospitals so that they can say, we can provide that treatment, but we also have the capacity to provide that education and to report to the courts. And we want to do that across the continuum. So inpatient, outpatient, and like Sue said, even in the jails, because some people could really, you know, quickly be restored to competency without ever having to move them from place to place.
All right. Is that the heart of it?
Yeah, that's the gist of it, Senator Abler. And I just want to say that none of this, I'm going to be honest, is free, right? That there are resources that are going to be needed to put this into place, but it also might be a better use of resources than what we're doing now. But I just want to make sure people know that there has been a group really looking at this, looking at what's happening across the country and really having thoughtful, deliberative discussions about how can we address this issue. So thank you.
Yeah, well, I appreciate the discussion. As I said, this is just cracking the lid on this topic. And at some point, we're going to decide, really the question it seems like we're asking is, whose job is it? Doesn't the county already have a responsibility with their case managers and, you know, creating a forensic navigator? What's the difference? So we'll have to sort through that. But I think, hopefully you see this as a benefit to bring this up. And I saw our next testifier is Michelle Simpson. What got my attention here was the gap cases. I was wrong. There's 696 of them, at least as of July or so. Well, I won't. Well, and some of them are not tame. I mean, they're dangerous. So. I guess we'll just let Ms. Simpson tell her story about one of those and a tragedy. So Ms. Simpson, welcome to the committee. I'm really glad you can be here.
Thank you. Senator Adler and members of the committee, I really appreciate having the opportunity to speak. Just listening to everyone talk so far, I haven't really heard anything about public safety. So my 21-year-old daughter, Abigail, was murdered 18 months ago on February 26, 2020 in St. Paul, Minnesota, Ramsey County. Abigail, I'll just say, you know, she was a loving, smart, compassionate young woman. She was a sister and an aunt and was really deeply loved. And, you know, I'm just trying to give like a face to like, there are actual victims that are from these decisions, these policy decisions that are being made. So Abigail was beaten and stabbed to death Her last moments on earth were horrifying. My hope was that she didn't suffer, but she did. It was very bad. And words obviously cannot describe the pain and grief that I and her father and her brother and sister have experienced. And I sit here and I don't cry before you, but I've had 18 months to cry and think and not sleep. So I'll never be the same. The individual who murdered Abigail was civilly committed, but provisionally discharged in the beginning of May 2019, which is 4 months after the change in the DHS policy, with suspended felony charges without having his competency restored. He was connected to county services. So I also didn't hear, it makes it sound like, and when I listened to the discussion, that we have these things in place for civilly committed individuals who are provisionally discharged and they have a plan of care. But people don't just decompensate in jail, they decompensate in the community as well. So I also want you to know that it's important to know that Abigail is not the only person that's been murdered in the last 18 months. She's one of 4 that I know of, by individuals with either dismissed or suspended criminal proceedings due to a finding of incompetency. 3 of those individuals were civilly committed. So in theory, it would have been connected to treatment services in the community. So the presentations today, I'll say it again, in the interim and final competency restoration reports have almost no acknowledgement of public safety. It's actually astonishing and disappointing. I note that Dr. Stevens did have a slide on positive impact. So I think we also need to look at the significant negative impact of the current statutes and these policies and try to do some prediction of what, I don't know what a forensic navigator would do anymore for the person that committed Abigail's murder and the other 3 in just the last 18 months. So competency restoration programs should exist to protect both the defendant and the public. This is stated in other states. Now, I know no state has this. This is really complicated, a very complicated issue. I get that. I'm a nurse. I understand it all, most of it, more than I want to actually now. I also want to say that thousands of individuals not restored to competency are living in the community in all states. In Minnesota, it looks like 25% of the defendants incompetent to proceed in court are restored, only 25%. So 75% are not, and they're returned back to the community or jail. So this isn't working. Abigail's and others who have been murdered or assaulted are evidence of that. So I have a few requests. I ask that this committee reevaluate the focus of the task force or form a different task force and include public safety as a priority area as part of attempting to find a solution to the treatment and public safety gaps. I also ask that the committee request and review more specific data as it relates to negative outcomes of defendants who are deemed incompetent, such as type of crime committed when deemed incompetent, and then if any subsequent crimes were committed. I think this might help establish a bit more of risk prediction. I don't really know. I mean, it's just complicated. So finally, the civil commitment statute was not considered by the task force in addressing these gaps, but this just doesn't make sense to me. It seems counterintuitive, as it clearly overlaps with competency restoration, at least some of the time. So I ask that a comprehensive review of the civil commitment statute and provisional discharge component be analyzed for ambiguities, mental health care gaps, and various process flaws before allocating any more money. I know Sue won't like that I said this, but to an already complicated and I would say very broken system. So I started with talking about my daughter, Abigail. She is why I'm here before you today. I will end with what I know her wishes are. Abigail would want everything to be done possible to prevent a brutal death like hers. I really sincerely appreciate Senator Adler inviting me to speak, and that this committee take time to understand the committees or the complexities of these issues. And I appreciate the opportunity to speak. Thank you.
Yeah, thank you. Wow. Appreciate you coming forward. And actually, I appreciate all three of the testifiers. I think we've got a pretty broad look at this, and just in the words of some of the people I've talked to, it's a mess. But there's some huge gaps. 696 people who are, at least as of whatever date that was a number, it's still a big number. 200 or so are in some kind of county jail somewhere, and the rest of them are just kind of floating around. The fellow who shot up the Alina clinic, his name was Ulrich, he was in that gap. He had committed some crimes, misdemeanors, one of which was violating an order of protection, which is only a misdemeanor. Had that been charged, he was dismissed. He could not have bought a gun. So it just, you know, there's some commonality here where we just have to get our arms around it. While at the same time, with respect to you know, NAMI and Ms. Abderholden and the concern for the individual. But when I started looking into this, I was concerned, as Ms. Simpson pointed out, that I saw almost no concern about public safety, at least expressed in the report, even though all those law enforcement folks were there. So anyway, part of it lands on us in our committee, part of it lands on public safety, part of it lands on judiciary folks. And so, but I'm hoping to start the dialogue today, and I don't want any more stories about Abigail in the world. It just should not be. It should not be. Anyway, so thank you. And so we can discuss this for a few minutes, and then I think I'm hoping that, you know, Ms. Abderholden and others, if you have recruited somebody, I should have invited Senator Sen John. I didn't realize he worked on this before. But are there any, Senator Hoffman, I see your hand up. And if I don't see your hand, just don't be shy to interrupt.
Thank you, Senator Adler. Mr. Chair, thank you for this discussion. You know, I wonder, one of the things that Sue or Senator Sen John might take back is there seems to be civil commitment on multiple, I see the term all the time, multiple occasions. Every time there's been some kind of reoccurrence or something like this occurs, which is just devastating. What's the system? What's the missing gap in the system that can help stop this multiple? I've been through multiple times. Where is that care and treatment side? And I guess I'll look forward to Sue's report. There's got to be some legislation we can do to make the system a little bit stronger to help make sure that somebody doesn't repeat through multiple times going through a system of civil commitment, Senator Adler. That seems to be a public safety concern there. And I want to make sure I premise that I'm not talking about devaluing somebody's personal rights when it comes to their unique and individualized needs with their mental health, but the system itself, I think that gap we need to address. And I look forward to trying to help fix that with you.
That sounds like a comment. And I appreciate that. I think that's where we have to go. Really appreciate that. Anybody else want to offer a comment? I think this has been a pretty good start, but I don't want to cut anybody off. Looking for hands. Well, I think we succeeded in opening up this discussion. I think it's very much in our responsibility area. And whoever takes this on, and I hope that, you know, Senator Sen John or others, I think we'd be nice to have a couple of folks. Unless anybody else has a final comment, we're going to put this aside. I really appreciate the discussion. I think we kept it high level and respectful, but still pointing out some of the gaps. And so thank you all about that. Let's move on about a much less, more simple matter, the FMAP discussions. We had just a boatload of money, barge load, wasn't it? Commissioner Wheelock talked about a barge, barges of money a couple of years ago. So Ms. Bailey, and you want to give us heads up on some of this, and we're going to talk about at least one specific area and maybe some other questions as well. So welcome to the committee.
Thank you, Chair Adler, and hello to committee members. I'm Elise Bailey, Fiscal Policy Director for the Department of Human Services, and I think my coworker, Matt, is going to put the slides up. Here we go. So I'm going to quickly go over some really key and significant investments we're making in our home and community-based system through our spending plan, and provide some updates with that and some public comment we've received with that. And I'll try to go through quickly so you have time for questions. So we can go into it. Let me see, okay. So as some background, the American Rescue Plan is a federal law that passed in March. And as part of that law, they authorized a temporary 10 percentage point increase to states' medical assistance FMAP rate. So medical assistance, or MA, Medicaid, is funded through the federal government and state government, and typically will have X percent is paid by the feds and X percent or Y percent is paid by the state. And what this law said is for certain services under your MA program, we'll pay 10% more. As a condition of that, states then have to take that amount of money and invest it right back into our system for the home and community-based system with activities that will expand, strengthen, or enhance our system. In order to qualify for this money, we had to submit a spending plan to CMS detailing what those activities are, and they have to approve that. And then throughout this time period that the money can be spent through 2024, we have to provide quarterly reports updating them. The next slide will go through kind of the timeline. Now this was pretty quick. They passed the law in March, and between March and May, we didn't really know how the feds would define home and community-based services, how states could qualify for this money, and what the processes would be for us to spend the money. So on May 13th, they issued guidance to us, and lucky for us, that was as we were wrapping up the regular session. So we spent the next month, the legislature spent the next month kind of detailing what would be in the plan, specifying those items in House File 33, and then appropriating the funds corresponding to those. So that bill passed on June 29th. We had to submit the spending plan initially by June 12th. Luckily, CMS gave us an extension to July 12th. And so we had a quick 2 weeks to turn around and submit to them what that spending plan would be. In the meantime, we also posted what those items are for public comment, so we could get some comments from the public on what their opinion is on those items and get some kind of feel for how we would implement them. So that was up from July 9th through August 12th. So some initial figures on the kind of money we're talking about here. Initially, we projected it to be about $686 million that we would receive from the feds due to this enhanced FMAP. That estimate was based on our forecast, so how much we think that we will have claims in this particular area of our Medicaid system. And so that will, of course, shift as we actually pay those claims. In the bill and in our spending plan, we had $684.8 million of spending. So those two rows at the end of this period will have to equal, or the spending would have to exceed what the revenue will be. And so, as I said, the revenue will shift due to actual claims we pay, but the spending will also shift due to actual claims under the spending side, as well as changes in implementation timelines and things like that. So we had over 50 different initiatives in our spending plan, and I could spend hours probably talking about all of the important items that you chose to invest in. And so I'll kind of highlight some of the big ones. I'm not going to go over every item in the plan, but we'd be happy to come back and go into detail about each item. But so over 50 different initiatives included in the plan. We segmented them in our plan based on 5 categories. So provider rates, expanding the services under our HCBS, supporting people to live in their own homes, planning and implementing important system reforms, and then lastly, supporting the infrastructure. And a lot of the items under this are like grants outside of the Medicaid space. So over 60% of the funding in our plan is used for provider rate increases, and this section is huge. I mean, not only are we providing 60% of that $686 million in rate increases, but these rate increases are ongoing past when this temporary federal money is available to us. So huge reforms in our home and community-based system in this space. I would point out the PCA rate reform was the biggest one-time increase we've had in the history of our program, about a 10% rate increase. So that one in particular was monumental in our system. Next slide. The next category is expanding the actual services that we provide under home and community-based service structure. So some items in this are expansion of the use of telehealth, implementing community-first services and supports, providing different criteria for accessing enhanced rates for PCA, and implementing integrated community supports on the DD waiver. We also had a section on supporting people to live in their own homes, which is a big, I know, priority of this committee as well as our agency. So under this, we provided housing stabilization services, so expanded what will be available under that benefit to include transition funds. We added to our community living infrastructure grant to local entities. We have some funds to support people to move from provider-controlled settings, accessing respite support, and providing technology support to people who are receiving HCBS. So there's also a lot of items in the plan that really seek to reform the system ongoing in pretty big ways. So in the plan, we have the phase 2 of Waiver Reimagine, and the development of an individual portal so people receiving home and community-based services can access their information, their plan, what is paid under their Medicaid services through an online portal. We also have case management redesign, uniform standards for mental health, and looking into new services for people with disabilities who are parents. We also have several studies, such as studying all of our outpatient and behavioral health services, looking into our safety net and making sure safety net services and making sure that we as a state adequately support the needs of people across the state, you know, reducing reliance on congregate care settings. So there's many items in this list that were, you know, these funds will be used to set the stage for future reforms for many years. And then we have some task forces. So the plan begins a task force on looking at the phasing out of subminimum wage, and in conjunction with that, providing grants to providers who choose to phase out the use of subminimum wage right now. We also have funding for a task force looking at background studies and how we can standardize that and ensure that our laws and our rules around background studies meet the safety needs of people across the state, as well as ensuring, you know, our workforce is there to provide services. And then kind of looking at our mental health system and ensuring that we have a culturally informed and culturally responsive healthcare system as a whole. And then we have quite a few grants in the plan for a variety of services and reasons. And I didn't list them all here, but some of the big ones are really this new grant that we'll be rolling out, looking at supporting the capacity of providers in underserved communities. So trying to enhance the services that would be available to people across all of Minnesota. We have some funds in the plan to work on workforce, so how we can dedicate funds to ensure that direct care staff are there and there to provide services, and so we'll be working on that. So this is a long list. We have age-friendly Minnesota. So we have some funds in there to ensure that our communities across the state are age-friendly and we can push forward important reforms there. And then, like I said, lots and lots of grants, things for grants like self-advocacy grants, looking at inclusion initiatives, inclusion childcare, quality improvement through the customized living services. So lots of really great stuff in this space. So as I said, we collected public comment for about a month, and I want to let people know this is certainly not the only way that we want to hear from folks on this plan and on how we'll implement the initiatives in the plan. But it was just one formal way that we could collect information from people. We received a total of 73 unique responses, and it varied from a wide variety of people and perspectives, such as people with disabilities, parents, providers, lots of counties and advocacy organizations submitting comments. Overall, most of the comments were actually areas of support where people were indicating happiness towards a lot of the items in the plan. The main takeaway were people were happy about the rate increases, the PCA changes, many comments about the technology assistance for people receiving HCBS and grants available to providers serving underserved populations, and also strategies to support people to live in their own home. The most common comment was really related to our direct care staff shortage and ensuring that the dollars really go to increasing those staff wages, as that is a big barrier. It has been for quite some time, but the pandemic has really brought out some challenges in that aspect. And then many comments did recommend other ideas or initiatives, such as access to affordable housing, strategies to increase access to employment, increasing hours available to people, and increasing budgets through the Waiver Reimagined space. It's really hard to summarize all of the comments that we received, but here's, this is just a one snapshot of what we've received, but we will look at all the comments we've received and take that into consideration as we implement them. So going into CMS approval and where we are now. So like I said, we submitted the plan on July 12th. We were told that CMS was going to look at and approve and send feedback within 30 days. Now, that hasn't happened. We haven't received approval and we haven't received anything from CMS related to that. The sticky point on that is all items in the plan are contingent upon this federal approval. So this means that all rate increases, grant programs, even admin costs, so we can't even hire people to implement the provisions until we get this approval. So we're kind of in a waiting pattern. We learned on Monday that CMS received plans from all 50 states and DC, and that about 25 have received anything from them. Most of them, it sounded like none of them got a full out approval, that most of them, they all got either a partial or conditional approval, with partial being defined as, we'll approve some things, but we have questions about this list of stuff that we want either you to take off or respond to questions on. And then conditional approvals, we'll approve you to get the FMAP, but you have to do X, Y, Z throughout the period. They've told us that they will, that they'll give us written correspondence by the end of the month. So that's what we know at this point in time. So our next steps, we're anxiously awaiting that correspondence. We're trying to do our best to prepare implementation in the meantime. And there's a lot that goes into that, such as rate increases that go into our MCOs, NCO rates, systems work. There's also other federal authority requirements. So most of the rate increases also have to be approved through our waiver and state plan. So we're trying to work as much as we can on the things that we can control while we wait for approval. On the fiscal side, we're also updating revenue and spending projections, and it shouldn't be a surprise to this committee, I guess, that things will shift quite a bit. So the revenue projections will be based on the actual claims experienced and a more defined analysis So that $686 million figure will shift. And then the spending projections, like I said earlier, will also shift. We've of course have this delay in approval of the plan, so that might play into, reduced spending in some areas. The estimates will also be updated based on the forecast. So things will shift just sheerly because of that. And then of course, those two things have to equal in order for us to kind of meet the requirements of CMS. So it will be an interesting process going forward. So that's what I've got for you as an update at this point in time. Happy to respond to any
very
questions.
helpful. And so I was interested we didn't spend all the money, which I thought was smart anyway, saving $1 million or so. The number just kept going up and up as we had, oh, hey, another 100 million. Oh, it's 600. I mean, it's not likely to ever happen again. But we tried our best, and I just wanted to thank you and the department. I think you said the legislature I was hoping that we would be part of the process, that there would be a legislative piece, but it was very much a we, the House and the Senate and the administration and whatever, DHS. It was very much a we thing. The only we that wasn't there as much as I would have really wanted would be the public, just because of COVID and the way that we were working so remote. And that was why I was glad to look at the comments. And there's at least two things we have to talk about. I wanted to bring up the first one about the sub-minimum wage task force. And I think, well, I'll be honest, I think we could have written it a little better than what it was, but it was just, that was one of the last things we did. We didn't get to shop it like we might have, and I'm actually working with Senator Hoffman. I think we need to add some more families into that task force. And I have not reached out to Senator Schultz yet, but I hope that she's open to that. And I think we also want to talk about specifically what happens to individuals who truly need, that there's no other option for them but a sub-minimum wage thing. And it's a good number of those. And so I did not mean to, get people as concerned as they've gotten, and I respect the concerns very much and frankly share them. And so there were several replies about that. And then, I think that hopefully we can have some discussions about that. But I just want to remind folks why we even put that in there. There was all kinds of rumors that the feds are going to change, that we even have that option. And if we don't discuss it, then we're going to find ourselves really in a bad way if it does come up that way. Anyway, so that's what that's about. And so I'm happy to take all the comments, and Senator Hoffman probably as well. So, and then other members of the committee if they want to address that. Senator Rutke.
Yeah, thank you, Mr. Chair. And you kind of just touched on what I was going to add to as Ms. Bailey went through what was all included. And the one thing that jumps out at me, and has from the time that we discovered it in the bill, and that was a sub-minimum wage. To me, it's an absolute disaster for our clients that fit that group within our day services. And my first inkling and request has been to eliminate all of that language, but if there is some things there that we're worried about from the feds, let's have that conversation so that we can draft the bill accordingly. But we need to make changes, because just locally, and I know my area is no different than lots of areas around the state, we would eliminate jobs for a lot of these clients who thoroughly enjoy what they do. They're working with their friends, but they just don't have the capabilities to work at something that pays a minimum wage. So what are they going to do? They're going to be stuck in adult daycare. So let's continue the conversation. I appreciate this, but we need to go forward with eyes wide open so that we don't eliminate people from the jobs that they currently have and love. So thank you, Mr. Chair.
Oh, very well said. And I welcome your help on at least cleaning up the language. And I want to also point out to as you read it, not just, there's no implementation language. It's a group is going to sit down, and hopefully a larger group with more wide interest, which I wish we would have included in the beginning. So I accept all the comments and we'll sort that through. So thank you, Senator Upke. Anybody else on this segment? And then otherwise we'll move to Mr. Coleman to talk about elderly waiver. Not seeing it. So Mr. Coleman, welcome back. And, appreciate you being here.
Thank you, Chair Abler, and good morning to all the committee members. I'm Lauren Coleman, mostly retired, but and a former assistant commissioner at DHS. First, let me thank you for your support of the disproportionate share elderly waiver legislation. It's a very important initiative by the state of Minnesota to provide an opportunity for low-income seniors to have the option of living in a modern assisted living with private apartments and many amenities. Unfortunately, although it was commonly known what the intent of the legislation was, the implementation has been disappointing and will prevent many assisted living providers from participating. Changes made during the last days of the special session without stakeholder input produced this effect. Let me explain. Many assisted living providers, especially those serving low to moderate income residents, have fair housing obligations. Each of the sanctuary committees have an agreement with the city it is in to allow a specific percentage of apartments to younger seniors from age 55 to 65. This was explained through the technical consultation process. It was acknowledged in the initial fiscal note that I reviewed, where the impact of the elderly waiver, CADI waiver, and brain injury waiver were fiscal noted. At some point late in the legislative process of the special session, specific language to exclude CADI enrollees from the disproportionate share rate floor was inserted. So the result is that the department excludes CADI enrollees from payment, some of which are over the age of 65, from the rate floor. But the decision was made to include them in the overall population of the community. It makes it next to impossible for a community to meet the 80% threshold to qualify for the legislation. Had this been known prior to adjournment, it's possible we could have come up with appropriate language to meet the objectives of this very important legislative policy decision. I have suggested an administrative option to DHS that would focus on seniors in the assisted living communities and make it more feasible for providers to access this special low-income program, but the department declined to accept the suggestion. We continue to have discussions. I would urge the department to reconsider so the intent of the disproportionate share legislation could be realized. If that does not occur, some assisted living communities that have been waiting for this legislation in these unprecedented times may be unable to continue serving low-income residents, or they may default on their bonds, or they may need to ask the current CADI residents to find other suitable housing and service arrangements. In closing, I continue to be committed to this initiative, and on behalf of low-income Medicaid participants and the providers serving them, I'd be happy to answer any questions you may have.
Well, thank you. And I'd like to hear the department's reply to that, because you know, when you're that, I don't know, Harry Truman said the buck stops here, and it stops with me. But there was so much flying around, just to, not looking to defend myself, but it's, the intent we had all along was to keep these places open. So who from the department is here to talk about that?
Chair Abler, I can speak. Thank you, Chair Abler. So I can speak to the fiscal note and what the change was made from then to now. So the fiscal note and the bill itself has two distinct items. A, how a facility is eligible to be called a disproportionate share facility. And in the bill, it said 80% of their census, or the people that live in their facility, need to be elderly waiver recipients. So that was one item. How do you become eligible? And then the second item is who gets the rate increases? And so in the original bill, how you become eligible, 80% of your census being elderly waiver recipients. That was what the bill said, and it applied the rates then to any disability waiver or elderly waiver recipient in the facility. What changed at the end of session was not the eligibility for being declared a disproportionate share facility. It was just to who the rates would be applied to. It would not be applied to BI and CADI recipients. And so I believe Mr. Coleman's concern is really around the eligibility for being declared a disproportionate share facility. And the way we're implementing it is the way that the law reads. It's pretty plain language. It reads 80% of the facility's recipients have to be EW recipients, and that's how we're implementing the law.
And Ms. Bailey or Mr. Coleman, was that the way it was introduced with that 80% threshold for elderly waiver? That didn't change along the way, is that true?
That is correct.
So, well, that's helpful, I guess. So the threshold didn't change. I'm feeling kind of better about that for me, at least, to be the slacker chairman here. But the question is, who can be compensated once you get above that? And so if you already have 80% of the elderly waiver clients to get in the door, at the most, there's 20% more people that you could get paid for if you were maxed on such waiver services. Do I understand that right, Mr. Coleman?
Well, typically, an assisted living community would have some amount of self-pay or private pay residents.
Right, but I mean, so to get in the door, you have to have 80%. That was the bill that was carried by whomever in the beginning and to the end. And at the end, the change that happened is if you have any CADI or other such individuals, that they could have been given a rate increase as well. And that changed. I just want to help understand change. All right.
That would be correct.
And Ms. Bailey, did the fiscal note change then at the end to reflect that change? Was it reduced then?
Chair Abler, the bill language changed, but there is an error in the tracking for the final bill that accidentally has still the line of the disability waiver programs.
All right, so we did pass that. And so in the bill language, so that's actually, it's a policy change and the cost of it's reflected in the fiscal note. That's why I didn't pick up on it. So because the number never changed in that. And so is there a minute? So we should probably take this offline a little bit, but I'm interested in the administrative fix, and I don't want to burn up the committee's time on this now, but I'm happy that to talk about it. I see Mr. Pollack has his hand raised.
Mr. Chair, thank you. I don't want to add a lot more time to this debate. I think what Ms. Bailey is saying is correct, that there are certainly options for, a budget neutral fix, but the administrative fix that Mr. Coleman is describing is not a budget neutral fix. It's a pretty dramatic expansion of which kinds of facilities would be eligible for the rate floor. If you had a 100-person assisted living facility, 5 elderly people, and just 4 of them are on EW, they would qualify. I don't think the legislature intended for 4% to be, 4% of your residents to qualify you for this floor.
Right, and now I'm going to start getting confused here. So so Mr. Brennan, I think we need to sit down and if you can connect the time with all of us. But I appreciate it coming to light. I just want to remind everybody that the intention was to encourage people who are taking care of elderly waiver people at no great profit margin to keep doing it and to bring more providers in. And I'm going to continue my little mini tirade here about assisted living providers who have chosen to take the high dollar people and spend them down to poverty and then kick them out, which I think is intolerable. And so this is an effort to try to do a carrot thing. And so I think we need to find a way to reward providers who are actually caring for the people who have the greatest need. And that's just my opinion. So I think with that, we'll set this aside.
Chair Abler.
Oh,
Chair
yeah,
Abler,
Mr.
can I respond
Please.
to
Please, yeah.
Commissioner? The example he used is not accurate to what I had suggested, and I will follow up with him to explain why that that provider that he just explained as qualifying would not qualify under my suggestion.
Yeah, well, I appreciate that. And I'm going to remind everybody that the people at the table on this topic are all amazing service-minded folks. And so I think the administration agreed with the object of with the goal, and we just don't want to lose any more elderly waiver beds.
Jim, Senator Abler.
Senator Hoffman, yeah.
As long as you're in that bucket, Dan, when you guys are having the conversation, I thought we had taken care of elderly waiver when it came to the spend down, but I'm hearing that we didn't. So if you also want to approach that, and I don't know why, is that true, Dan? Did we eliminate the spend down in the elderly waiver side when we did the Medicaid spend down piece? We did not, did we? Yeah, that's what I thought.
Mr. Pollack, you have to use your words here.
Senator Abler, Senator Hoffman, no, there is still a spend down requirement. There are some expansion waiver options like alternative care or the essential community supports program for people that are a little higher asset or don't quite qualify in terms of their acuity.
All right, well, our work is never done. I want to thank you everybody for this topic here. Let's move to the child care stabilization grants. And this is something else we're not going to solve today, but Ms. Yang, I guess you've got a presentation for us. And on this conversation, we had like 150 letters. Some were happy and some were just beside themselves with concerns. And I'm concerned about all those concerns. So Ms. Yang, welcome and go to town.
Good morning, Chair Abler and members of the committee. I am Cindy Yang, Child Care Services Director at the Department of Human Services, and thank you for inviting me to provide an update on the new Child Care Stabilization Grant Program. I do also have Deb Swenson-Klatt, the manager of the unit that oversees the Stabilization Grant Program, has joined to help answer any questions that you may have. Next slide.
So specifically, let me just help you focus your comments, and we're burning up more time than I thought we would already. But if you can focus in particular on the licensed homes as you go through your comments. No one is unhappy at all in the center. So you can just kind of mention that a little bit, but if you can just, kind of edit your comments to focus on that, that's the real question that we want to talk about. So thank you.
Great. And we do have a slide for that too. I'll just move quickly through some background information here. At the end of June, during the 21 special session, the Minnesota legislature created the Child Care Stabilization Grant Program to stabilize Minnesota's child care industry during and after the COVID. And so our providers across Minnesota, of course, have steadfastly served children, families, and communities throughout this challenging time. And so we are grateful for all that they have done and thankful to the Minnesota legislature for its continued attention to the financial needs of this important part of our economy. And so the Child Care Stabilization Grant Program was originally established in federal law as part of the Federal Child Care Development Block Grant and through the American Rescue Plan Act, also known as ARP, in March of 2021. And so the state statute provides further direction on purpose and uses of the legislature, allocating a total of $304 million in ARP funds for this program. And of that, $299.4 million will flow directly to providers. Next slide. So just really quickly here, the ARP funds and accompanying guidance direct states to establish a child care stabilization grant program with requirements for both states and child care programs receiving grants. And so what you see here are the guidelines that states must be following. And so I won't read through here, but you do have the slide decks that we made available as well. Next slide. The statute for state requirements, state statute also provides direction to DHS and child care programs receiving grants focusing on Minnesota's program on child care workforce compensation, as well as providing relief for financial hardship. And so DHS must implement a grant that provides 3 types of grants. First is the transition month grant, second is base grants, and then lastly, financial hardship grants. These grants we must provide grants from July 21st to June of 2023, with amounts of base grants reducing after 1 year. And then the award amounts for base grants on the number of FTE employees who regularly care for children. And then also, it's important to note that in addition to meeting federal requirements, childcare programs receiving the base grants must also agree to use at least 70% of the base grant to provide increased compensation or benefits to employees who regularly care for children. Next slide. This slide is just a quick visual of the 3 types of grants described in the previous slides that I just mentioned. Next slide. And it is also important to note that this new program follows a previous program that helped providers stay open and operating during the pandemic. This program was the COVID-19 Public Health Support Funds for Childcare Program. It was available from July 2020 through May of 2021. That successful program was similar in many ways to the new stabilization grants program, but also has some key differences too that I want to just take a quick moment to call out here. The purpose of the Public Health Support Funds for Childcare Programs was to support the ability of childcare programs to follow public health guidance during the COVID-19 pandemic. And then the purpose of the Childcare Stabilization Grant Program is to stabilize the childcare sector during and after the COVID-19 public health emergency. For the Public Health Support Funds for Childcare, they were available for 10 months, as I mentioned, July 20th through May 21st. And then the Childcare Stabilization Grant will be available for a total of 24 months, for which 2 months were transition month grants, which are already completed, and then 22 months for base grants. We're still designing the financial hardship grants. As for the grant size by program type, the grant amounts for public health support funds for childcare varied by program types with different lower grant amounts in different months. And so family childcare did receive $1,200 per program. That was reduced to $600 in April of 2021, for example. Childcare centers received $8,500 per program, reduced and provided in 2 tiers with about $4,200 for smaller centers and then $5,500 for larger centers in April. And then certified childcare centers received $3,000 per program, which was reduced to $1,500 in April of 2021. In this first year, the base grant award amounts for childcare stabilization grant program are $430 per full-time equivalent employee, contractor, or sole proprietor who regularly cares for children, plus 10% for programs serving children who receive childcare assistance or the early learning scholarship. These amounts will decline incrementally after the first year, which is consistent with requirements in state statute. And then
Ms. Yang, what is the common number for a center under the new proposal? How many FTEs do they generally have? Like for a 100 child place, how many FTEs would they have? Like 10 or more than that?
That's a great question. I don't think
Just a ballpark.
I have that number. Yes.
Okay. Well, that's fine. Thanks. Just keep going.
Yeah.
You can phone a friend later. So just keep going. Yeah.
Okay. Great. Sorry, just looking at my notes here. As far as how the grants were determined, the grant amounts for public health support funds were based on an estimate of the impact of following public health guidance, whereas the grant amounts for stabilizations were set based on state statutory requirements. Next slide. Over the past 10 weeks, we have worked very quickly to plan and implement this new program. We developed a program informed by stakeholder engagements conducted with representatives from all program types and childcare experts, which occurred in spring of 2021. We've awarded transitional grants for June and July. We've communicated base grant requirements to eligible programs. We've also partnered with our technical assistance provider, Child Care Aware of Minnesota. We've set up the application process for base grants, which I wanted to also mention that opens today. And then we began development of financial hardship grants. Next slide. That does end the formal presentation update about childcare stabilization. So we'd be happy to take any more questions, and you're able,
right.
If you can know if we've addressed them too.
Yeah, so someone just texted me that centers have an average of 15 to 20 employees. So they're going to be getting, you know, in the range of what they got before, maybe 10,000 or something, you know, 8 to 10,000 perhaps. So here's the concerns that I'm hearing. And I, again, at the end of the day, I'm the responsible party here on the Senate side. There's definitely a fog of COVID, you know, discussions going on, and we had meetings, and I'll just tell the public, doing bills in private and COVID is a lousy way to do it, I'll tell you. Not for any bad intent by anybody, just they don't get the benefit of oversight and comments. And so I think this is going to have to go offline as well for some more discussion. And I think I have a meeting next week, and probably you'll be there, and maybe you should bring a couple of advocates along. But it seems like you are not accusatory, but it seems like the state has made this more complicated than it needs to be, requesting some information that may not be required, which is very burdensome on the licensed homes. And I'm happy the centers are going to get their money, and that was important as well. So, but as we implement a program, it seems like some things are made more complicated and information was being requested. That is someone's decision to request that. And if we would have had testimony, we would have had 20 people talking about this. And so we need to sort out what the federal guidance requires, what the law that we wrote requires, and in my opinion, make it as simple as it can be. It was my understanding that there would barely be an application, that these other second round public health grants went out just kind of automatically to people where they filled out a little form, and hoping it would be on the same order as that. And then in terms of the base amount as well. So those are the concerns that have come up in particular. And so Ms. Yang, if you wanted to comment about that, looks like he's locked up on my screen.
Sure, Chair Abler, members of the committee, thank you. I am aware of the concerns, and we would be more than happy to have further conversations about this if there are components that providers are feeling that we are not following federal or state statute. So, Chair Abler, I am aware of the meeting next week too, so we'd be happy to continue the conversation.
But I appreciate that, and and the trouble is, there's actually more centers than before, and decidedly less homes. And it just seems like there's a dualism here, which that nobody has a plan to replace the beds that we've lost in the licensed homes, particularly in greater Minnesota. And yet we struggle with this discussion over and over again. And I didn't have you come today to, you know, do anything except to try to get to the bottom of this. But it seems like it's an uphill fight all the time. And Senator Utke has talked about this many times. And so we just need to make sure it's as smooth as it can be, as fair as it can be, and actually tries to maintain those homes that we have, if not even open a few new ones, which seems like that's not the trend. So I think that's an important meeting, and maybe Senator Utke, you want to come to that one. Senator Wickland, welcome.
Oh, thank you. I think Senator Benson had her hand up as well, so I don't want to.
Yeah, well, go ahead.
Jump the line.
You were first, as I read. So.
Oh, okay. Thank you. Yeah, I'd like to just ask if there's any way that I could be involved in hearing your results, your discussions, or hearing more about the discussions. It definitely seems like there's interest in understanding better, where the differences are coming from. If it's language in the statute that they're following it and that's the way it's being implemented, we need to be careful about
Oh, yeah, for sure.
how we address the concerns. But if there are burdens in the application that, we
Well,
need
Mr. Brennan,
that would be
do you
great.
want to add Senator Wickland to the list for that, whatever that meeting is we have set? So hopefully she's free, and I would very much like you to be a part of it. And if we need to flex the time to accommodate you, that'd be great.
Okay, I'd really appreciate it. Thank you.
Oh, yeah. Senator Benson.
Here we go. Thank you, Mr. Chair. And similar to Senator Wickland, if the department could give some comfort to the committee, look at what you're asking, see what's required by the feds, by the state, and then if there are any other requests, if they could document why those were necessary for implementation, or if they're somehow otherwise required, so that way this team starts out with homework ready to go instead of having to ask that question in a follow-up. And if there's differentiation based on facility type, or if the department has recommendations for ways to limit documentation based on facility type. I know it's more work for these individuals, but I think it's also important that the legislature comes to a meeting where documents have been prepared that would meet legislative needs.
Thank you, and I really appreciate that. And actually, whoever wants to come to this meeting is certainly welcome, but that would be a time to dig a little deeper. And so, the stakeholder involvement, at least one person has texted me that there wasn't any stakeholder involvement on this part of it. So, Senator Nelson, welcome back.
Yes, thank you, Mr. Chair. And I've been in a dual tasking here. Unknown caller. In between a couple meetings. So my apologies for that. And then the phone keeps ringing. But I've been following along and I've gone through the testimony and the agenda. And I do want to also certainly volunteer to be part of this the child care stabilization grants. We know how important those are. And yet reading the testimony, but also hearing from my constituents in my district, there is a significant issue in how the funds are being awarded. And I do want to note, as we look at the child stabilization grant, child care stabilization grants, sometimes there are many ways that we address a problem. And so while I'm vastly concerned about how difficult it is for our family child care providers, and I have visited about that, I also want to note, as we look at this in a holistic manner, we should also look at, I believe, and Mr. Chair, you might be able to remind us of the exact amount, but were we not successful in getting, I think we'd asked for 20 million. I don't know that we got that amount for not necessarily the child stabilization grants. Of course, that was more like the 300 million range, but for our Minnesota Initiative Foundations to provide support for our family child care providers. I know they had done that before and it had been highly effective. Can you just add some insight into, or maybe someone, maybe Mr. Monahan, how we ended up with that? And then we want to look at the holistic picture here as we support our full, robust child care, both in our family settings and in the centers. And I think that would also include not just the stabilization grants, but also looking at how the grants for the MIFs in support of childcare have been a part of that as well. So I don't know, Mr. Chair, if you have that answer.
Yeah, if my memory serves right, we had 22.5 million for those improvement grants, and they were for minor renovations. You could not move a bearing wall, but you could do a lot of cosmetic and better work inside without doing major renovations. And Ms. Yang, maybe you can confirm that that number is right. And that process, there's an existing process already that we were going to use to make it more expeditious. Ms. Yang?
Well, thank you, Mr. Chair. And my further question would be then, are those grants, that 22 million to help with the actual facilities, which are certainly one of the large expense, are those available to family child care providers and to centers, or just to family child care providers? How are we making that distinction in those MIF grants?
They're available to both, but Ms. Yang, do you want to just take a minute on that, please?
Mr. Chair, members of the committee, my apologies, I had to turn off my video as I was having technology issues here. But regarding the MIF grant, that actually is DEED's program. And so I would say that DEED should be answering those questions. But
no, the question we have is the DHS grants for facilities. There was like 22.5 million for minor renovations. That is a program you're already operating, that you're going to continue to operate. Do you remember that?
Oh, I see. Okay. Deb, are you in position to respond to this question?
Well, I just want a short answer, but we passed money. I remember the negotiations, and I believe it's just a simple answer, like, yeah, we have them, and you're working on how to get them out the door, probably is what I would think the answer is. So if you're on a phone a friend, that's good.
Mr. Chair and members of the committee, this is Deb Swenson-Platt with DHS as well, and I can confirm that, correct, 22.5 million in American Rescue Plan funds were directed to facility grants, and we are indeed in the process of moving those out to Minnesota providers through a grant contract with First Children's Finance.
Right, and that's an existing program, and so I think that's good news.
So, Mr. Chair, if I can just
quickly.
Yeah, very briefly. I didn't mean to take that much time. I should have been more direct on my question. My question is then, as these are delivered, we must also look at them, just as we're seeing with the other child care stabilization grants, the 300 million, that there is a disconnect between how it's impacting our family child care providers and how it's impacting our centers. And I think we should be also looking at the same way as we look at these grants through the structural MIF grant. So I'll just, I think that's an important piece to remember.
But MIF is the DEED thing, and these are these other ones that are through DHS, and that's why people are confused. So I think if you're a member of the committee and want to be at that meeting next week, please send my LA Tom a request, and he will give you the Zoom information just based on who's coming. And I think there we need to talk about this topic. Why are these forms so complicated? I got a text from a child care center. It's hard for everybody. Why do we make this so hard? That's my question. When we don't have to, when we know that these people have been getting millions of dollars, hundreds of millions of dollars over the last year and two. And so this is meant to be a continuation of that. So let's keep it simple. And then I think we'd like an update on those 22.5 million. So how's that sound? I think that's good. And they will invite a couple leaders of the couple of interests, the centers and the homes, and just a couple of those that I will invite. And I think that'll be a good meeting. So that was really productive. So we're going to move on to an entirely different topic now. And that has to do with vaccine requirements at day services. And this is something that we are going to begin a discussion on. And if each of the testifiers can offer their comments, then we'll take some questions at the end, I guess. But the situation has to do with vaccine requirements of private businesses. When the private business happens to be a DHS facility that is taking care of some people who are themselves medically fragile or damaged by a vaccine. And so they're medically disqualified from that. How do we serve these individuals? That's my question. And how do we accommodate them when the very best thing for them is to be in person? So we have the DHS, we have a person from one of the centers, and we have two citizens who are going to offer their thoughts. And
Thank you, Chair Abler and members of the committee. My name is Kulani Moti, and I serve as the Inspector General here at DHS. And one of the areas that is in the Office of Inspector General is our licensing division. So I do have a few comments that I'll go ahead and I will try to keep this brief. And so in regards to our adult day facilities that we have, these continue to be challenging times for providers of day services, both day service facilities, which primarily provide support to persons with disabilities, and our adult day centers, which primarily provide support to older adults. During the peacetime emergency, a number of restrictions were placed on day programs to reduce the risk of spread of COVID, which include temporary closures, reduced hours, reduced capacities, social distancing, and health screenings. Since May 28th of this year, day programs have been able to operate without COVID-19 restrictions. However, programs remain responsible to ensure that they provide services to people in a manner that maintains and protects their health. Day programs have been able to offer some or all of their services remotely to assist persons who are not comfortable attending a group setting, or for facilities that could not ensure safe social distancing and other mitigation efforts. Each day program has made difficult decisions about how and when to reopen their facilities. All programs have approached how or if to fully reopen in a manner that best aligns with who they support. Some programs are doing so in a measured approach that brings people back in different stages. All programs must have admissions policies which must comply with the Minnesota Human Rights Act. This would provide protections to a person denied admission for an unlawful reason. Persons with disabilities receiving day services have a right to receive services in a safe environment. Day service facilities may terminate services if the health of the person or others in the program would otherwise be endangered. Similarly, adult day centers are required to monitor the health status of each participant, and participants are required to provide documentation that they are free from communicable diseases that would endanger the health of other participants. And this is set out in our various statutes and rules governing these programs. We encourage all service recipients to reach out to the providers if they have questions about if it is safe for them to attend their program or the plans for return to full services. If they believe that a provider is not providing services as required under statute or rule, they're encouraged to contact our licensing division to file a complaint or submit a report to the Minnesota Adult Abuse Reporting Center. In summary, I think these continue to be challenging times, and DHS continues to work in close contact with other state agencies to ensure that our communication and monitoring practices support the health and rights of service recipients. With COVID, we are presented with new information and new challenges all the time. The day program suffered to a great extent during this time. They were temporarily closed, reopenings came with restrictions, participants and staff are choosing not to return, transportation systems have been disrupted, and vaccine rates remain less than desired in some communities, and variants are creating new concerns. Overall, we are continuing to work very closely with all of the programs so that as they approach reopening or providing more services, they're doing so in a manner that works for the people that they serve and the staff that they have. So thank you.
And just one question and then we'll move on. So I appreciate how you said everything you said, and you said your words quite carefully, but there is no DHS protocol or MDH protocol that a place must follow short of their determination locally what they deem to be a good protocol. Is that right?
Protocol, Chair,
yeah.
Just to clarify, about that, you mean a protocol about vaccination requirements?
Well, about their opening. So when they reopen, there's no emergency powers in place, and so they have to abide by their interpretation of a safe standard. There is no official safe standard from the state requiring vaccines or disallowing vaccines.
Correct.
Right.
Okay. At this time, yes, there's not, and we work with them. There's that they need to ensure the health and safety, and then working with the other state agencies on this.
Right.
Yes.
And we'll discuss some more. So thank you. And so I think we'll just keep moving. Ms. Calvert, welcome to the committee. Are you here?
Sorry.
Oh, there you are.
Sorry.
Okay, good.
Oh, thank you, Senator Abler.
Nice to meet you.
Yeah, thank you so much, Senator Abler, for well, all your support during this very difficult time. And I just want to say a little bit, and I'll keep it very short. Interact Center for the Visual and Performing Arts is a center for artists with disabilities. We have people from the early 20s to their 70s. This is for people that want to pursue a career in the arts. We're 26 years old organization and the only one of its kind in the United States. We're staffed by 25 practicing professionals in the visual and performing arts. During the pandemic, we transitioned to a virtual program with 50 workshops per week in music, drama, writing, and a large variety of visual arts media. We also created a professionally produced virtual show with our artists called Zoomtopia, along with renowned Minnesota storyteller Kevin Kling. We currently have 120 artists with disabilities attending our program in-house and remotely. We actually grew during the pandemic because we were no longer limited to people that could only were, in our area in St. Paul. We've been bringing back artists in person gradually. Most of our participants will still be in remote learning for the time being. We're in a difficult position in this current moment because over 60% of our 120 participants have underlying conditions, including autoimmune diseases, and therefore at high risk for more serious effects of the Delta virus, in spite of the fact that they are vaccinated. Their parents and family members do not want them to come to interact if there are unvaccinated people here due to the recent news of breakout cases of the Delta variant. Before the Delta variant, we were planning on having everybody coming out back and did not think we would need to restrict people without vaccinations. But when the Delta variant hit, we reconsidered. Those artists who choose not to or cannot be vaccinated due to health issues continue to attend our remote program. We're following the DHS mandate that we're required to protect the health of our participants against transmission of communicable diseases. The nature of our work is we create performances. So there's singing involved. I mean, we're a theater company, a professional theater company where people work together and cannot always be 6 feet apart in masks and et cetera. So we don't have enough space to really, keep people separate. And the nature of our work is that we work in teams. So we're very worried that if one of our artists came in and got seriously ill, we would have to return to virtual only, or we would not be able to continue operating if a lot of our artists dropped out. We need for parents and family members and social workers to think that Interact is a safe place to send their family members and clients. We simply cannot jeopardize the health of our participants. We struggled all last year to stay in business. And if it weren't for the PPP loans and the COVID relief and being able to bill for virtual programming, we wouldn't be open right now. I know this is a dilemma many people that serve vulnerable adults are facing. And I just wanted to speak to this dilemma that we're in. And we hope when things get better, we'll be able to open it up to everyone, vaccinated or not. Thank you.
All right, well, thanks. And we have 2 parents, I believe. Ms. Carroll, welcome to the committee.
Thank you, Senator Abler and members of the committee. My name is Patty Carroll, and I'm speaking today on behalf of my adult disabled son as his guardian. He attends Interact. He is an actor. He loves his job, but he has been cooped up at home for the past 18 months and has been eagerly awaiting returning in person. Interact stated on July 7th that only vaccinated people could return to their normal in-person programming. I replied that my son had a medical exemption due to his prior vaccine injury but they did not address that at all and have not communicated with me in over 6 weeks. Interact stated that they're dedicated to the health and safety of all, but they're mandating a medical procedure that does not prevent the recipient from getting or spreading the virus. It's still in the testing stages. It has thousands of reported deaths and over 1 million serious adverse reactions, and for which there's no liability. I know of at least 4 adults who attend Interact who were also injured by vaccines. So Interact's decision to compel people to possibly be further injured in order to receive services shows me that they're really not dedicated to everyone's safety. What may help one person may kill another. My son knows that vaccines hurt him, and it upsets him every day that this is a topic of conversation on the Interact Zoom meetings. It's been an extremely difficult time for him, not only being prevented from going to the job he loves and being cooped up at home in front of a screen for 18 months, but more so because he is forced to listen to staff promote a medical procedure that he knows can harm or kill people. Interact claimed that the director of DHS licensing stated, and I quote, that providers are mandated by our adult day license to provide a safe and healthy environment free of communicable disease for all participants. I consulted with an attorney who indicated that it's not true that day services are mandated to prevent all communicable disease, because that's truly an unattainable goal. I then searched the licensing requirement and found no such mandate. I think Ms. Modi mentioned that they try to keep free from communicable diseases, but clearly they're not mandating any measures for AIDS, hepatitis, or any other communicable disease. So either DHS lied to Interact or Interact lied to me, I guess is the way I feel about that. Interact also claimed that if someone caught the virus at Interact and died, Interact would be ultimately responsible for that death. But again, it's not the responsibility of an adult day program to prevent all illness, so they could not be held liable. Their purpose is to provide services for disabled adults. Aggressively promoting a potentially dangerous medical procedure is way outside the scope of what a day program should be engaging in. Clients who are vulnerable to harm by vaccines deserve in-person services as much as anyone else. And if the belief is that vaccines protect you, any vaccinated staff and clients should have no fear of the non-vaccinated. I'm also really upset that Interact asked vulnerable adults what their vaccine status was without their guardians present and in front of other clients. This is a clear violation of privacy and a violation of the state statute saying that vulnerable adults cannot legally consent. They later claimed that they were obligated to ask about vaccine status, which I found out is not true. Senator Adler reached out to the Minnesota Department of Health to ask 3 specific questions related to facilities' attempts to require vaccines, medical exemptions, and discrimination. I was shocked that MDH basically disregarded his questions and replied with a general, unrelated statement. But the most alarming thing to me is that MDH and DHS are not informing providers like Interact of the simple fact that getting a COVID shot does not prevent the recipient from getting the virus or dying from the virus, and does not prevent them from transferring it to others. So anyone, regardless of their vaccine status, can spread the virus, which we see happening everywhere, every day. MDH knows the policy being pushed here has no basis in fact, but it seems as if they are allowing Interact and possibly other providers to write their own rules. So the last point I want to make is that doing services remotely is not a reasonable accommodation for an actor. My son needs to be with his peers in person, unrestricted, and not forced to test, mask, isolate, or be singled out in any other way. I hope this hearing will result in lawmakers becoming aware that MDH and DHS are not providing clear and factual data to day services providers, which is resulting in misinformation, discrimination, and ungrounded policies. Thank you, and I'm happy to answer any questions.
Well, thank you. Let's hear from Ms. Ogden. Are you here? Well, hi there. So
Hello.
a couple of minutes, okay?
All right, I'm Christine Ogden. Can you hear me?
Yeah, we can hear you great. Thank you.
Okay, I am the legal guardian and single mother of 2 adults with disabilities. One of them is a participant of Interact Day program. I am speaking on her behalf. Acting is her dream, and when we found Interact, it was a dream come true. She now can pursue her center-based goals and dreams. With her disability, she does not understand COVID-19, and she keeps asking to go to Interact. I kept asking when she would be able to start coming in person. It would not get a direct answer. Then I found out 2 different times she was asked online in front of all her classmates and teachers without my knowledge or consent if she was vaccinated. Even if everyone was told they did not need to answer, she does not understand that medical information is protected by HIPAA and that she does not need to answer that question. Especially with her peers answering can be a peer pressure. That is why she is a guardian. Now this information has been used against her and is not allowed to attend Interact because they are mandating COVID-19 vaccinations. Even before FDA approved. I emailed my concerns and told them she had a medical exemption and it was overlooked. My daughter is protected by the Disabilities Act medical exemptions, and this has affected the whole family. All she wants to do is attend her person-centered program in person and continue to pursue her dreams. As a family, being a single parent of 2 disabled children, it makes it very difficult to be at home all the times and be able to do other things that need to be done when she has to be online. So that has been a huge struggle for us. Thank you.
Well, thank you very much. And I think actually we've done a pretty good job of queuing up the challenge, and I see challenges on both sides. Senator Hoffman.
Thank you, Senator. The question that comes, regardless of the, somebody's individual process, but there is, I think, under Title I of the ADA, when it really talks about reasonable accommodations, and if I heard Patty correctly, there's a medical exemption or a doctor, somebody with the right acronyms after their name signed something that said the unique and individualized needs of your son can't have this because he's whatever, right? I mean, and if that's the case, isn't it an obligation of the employer to look at the Title I reasonable accommodation piece of the ADA? And if that's the case, then I don't know, maybe is Maren Halden or somebody from the Disability Law Center on this call that could possibly, that's the question, Senator Abel, that's out there. It's really about what is the reasonable accommodation that's needed, because there is a medical exemption here, right? It has nothing to do with anything else other than the fact that this unique need of that individual is a medical exemption. That's the focus.
Can I just say that I think that we
actually just, yeah, go ahead.
We believe that we have a robust virtual program for many. There are other people in the program that cannot come in because of this reason, and we feel that that's our reasonable accommodation, that we have a very robust program with 50 classes a week that's going on now. And the other issue is we have people with medical issues that had the vaccine that now they're saying they won't come in if there are people that are unvaccinated there. So we're in this in between most of the people are happy to stay in the remote program because it's been very, very successful. In fact, we're presenting at DHS about the success of this remote program and how interesting and entertaining it is. And we bring in guest artists from all over the country. And, you know, it's not less than our in-house program. So we feel that this is our reasonable combination until this Delta variant dies down or something, because we've had people become very ill.
So Senator Hoffman, thank you.
Yeah.
So what if part of the reasonable accommodation includes that a temporary, remote thing is not a good reasonable accommodation for their learning style and for what they need compared to that? We're not gonna solve this today. I'm trying to on this. This is gonna happen, and this is not to beat up Interact. Thank you. You're just in a vice here, and there's some follow up that you could do about privacy that you might want to work on, which seems like that's a problem. Senator Hoffman, and so the next topic is somewhat similar. So we're not gonna go very deep into this beyond this, but Senator Hoffman about this. And so maybe we need to have a follow-up to this as well, either publicly or privately. But do you know about a person needs to be accommodated in person? That is and the other stuff is so lacking, and they're not doing well at home, and they have to be in person. So what happens to that individual, independent of all the other individual desires that people have?
Hence, Mr. Chair, hence the argument, it's the unique and individualized needs of that person, right? When you're talking about a reasonable accommodation, that's the focus should be on that individual, and then it envelopes out on that. The thing that comes down to organizations or businesses will say, well, there's an undue. I mean, this is the same, Mr. Chair, this is the same argument when you and I have spent the last 2.5 years on the Connect 700 discussion and the hundreds of hours of dialogue we have. The undue burden that comes to play, state agencies will say that. So some people would say there's an undue burden, but I'm just setting that aside. If you just really focus at the real argument is about what is the unique needs of that individual, and then it envelopes out from there. And yeah, you're not going to fix it here. You and I both aren't attorneys, but I think the Disability Law Center folks, Maren Holden, Dan Stewart, Justin Page, clearly would have some idea of where this goes from that conversation. And but you're correct, Jim. It's got to come back to that individual, right? And then it envelopes out to the next discussion. Does that make sense?
It makes the sense. And I think it's really productive. And I think for the behalf of Ms. Moti, as they're giving guidance, and the Department of Health as they're giving guidance, they're giving kind of like health-related guidance, but they forgot the Title I piece. And so I think we'll have another follow-up meeting with that, probably privately. I think that'd be good, Senator Hoffman, if you don't mind. And if other members want to be a part of that, and could finally somebody comment, maybe you're the guy, Senator Hoffman, but could somebody else comment about HIPAA? Can you ask about somebody's health status in a public setting? Do you know that, John, or should I ask?
I don't play it. I played an attorney one time, Jim. Franzen's an attorney. There's a few other attorneys.
Does anybody know the answer to that question?
We did check.
Go ahead.
We checked on the language, and we checked on the language in the HIPAA rule, and you can ask someone. They don't have to tell you. We also, when this was happening, we said you can go in a breakout room. You do not need to answer this question in public. We were just trying, because we had the ability to get a lot of our artists vaccinated, and we needed to know who wanted a vaccination. It was in the HIPAA language that you can ask the question.
Yeah, I'm just going to opine, then we're going to move on to the next thing. I don't know that, I think one of the concerns from, I forget which, to the parents, if these individuals are under guardianship, I don't know that it's fair to even ask them those kinds of questions without their guardian present. So I think I think there's a challenge there. I don't know. We're going to try to solve that too, because this is going to come up more. And so you just happen to be the first one I heard about. God bless your company. But we have to find out, we're a policy committee as well as a finance committee. And so how do we handle this on a policy basis so that everybody is treated as fairly as possible and that the needs of each individual are met? So With that, we're going to put this topic aside, and I want to thank all the participants. Finally, the President Biden has done a bunch of things about mandates, but the one that was going on when we planned this hearing was about requiring nursing home workers to all be vaccinated. And so we wanted to talk about that too. So Ms. Rydrick, are you here? Thanks for your sticking in this long into the hearing. Are you there? Hello?
She's not muted, but her audio is not connected. So perhaps on her device, the mic might be muted because it's not showing as muted on Zoom.
Yeah. I can see you. We could write it out in note cards or something. Yeah. Call me maybe. That was one of the
Mr.
best
Chair, I think she's going to try calling in on her phone for the audio.
Okay.
So
thank you. I appreciate that. And while we're waiting for that to happen, I just wanted to do a couple business things. So I wanted to congratulate Senator Franzen for her position, and you know, how hard could that be? And I hope that she gets to stay with us on the committee. So I hope I haven't talked to her, but that's she's taken on a big task. She will be definitely up to it. And Ms. Johnson, you're going to be taking on a new role at the Senate. And Mr. Hauswald is, I don't know where he's going, but you know, you can kind of tell how you run a place, how many people leave your tenure. So I guess I've been that hard to work for. But, Mr. Hauswald has been amazing with his work. And I won't put you on the spot to have to make you talk unless you wanted to. But Ms. Johnson has just been stellar. So the future people that get to hire them are going to be really the beneficiaries of something amazing, some amazing staff. So, anyway, I see a phone there.
Are you able to hear me now?
Yeah, that's funny.
Okay. It's inevitable. Like no matter what device I use, that's the one that doesn't work. So,
hey, welcome to the committee. Nice to see you again. It's been a while.
It has. And just for the record, my name's Diane Rydrick. I'm the Acting Assistant Commissioner of the Health Systems Bureau here at MDH. And thank you for having us today. And it was an interesting hearing to sit through until the end.
Thank you.
So, Mr. Chair and members, you asked us here today to speak to the nursing home vaccination mandate. And it may be short. I will let you know we do not have really much information at this point about how that's going to be implemented. You all are aware, and you referenced this in your initial comments. There was a mandate that was announced in mid to late August. I think it was August 18th. And the announcement was that for nursing homes, vaccination would now be a condition of receiving Medicare or Medicaid funding. However, we have not gotten any information that. Our understanding from the conversations that we've had with them as recently as a few days ago is that they are in the rulemaking process right now, and they are not able to give us any additional information about that until the rulemaking process is complete. We think that they are aiming to complete the rulemaking process by the end of this month. But until we see an interim or a final rule, we do not know how they are going to be implementing the mandate. So we do not know if there will be a test out option or what any exemption process looks like. We don't know how they will be tying it to funding. We don't know when it will become effective. We do know that in Minnesota, we have just over 350 nursing homes that will be subject to this, but until we see the rule, we are not able to give them any guidance on what the specific requirements are going to be, what the timeline is going to be, or how we will then, in our role relative to the federal government, implement it for them. So we can share those updates as we get them, but at this point, all we know is what has been publicly released.
Oh, I appreciate that, and I was told that's all you knew. So You can't tell us things you don't know. Some people just make up stuff. So if you want to make up anything about how it's going to work, it's going to be amazing. The world's going to end.
Mr. Chair, I'll take a pass on that.
That's probably smart. Do you know, is it include elderly waiver facilities or just nursing home?
Mr. Chair, our understanding just of the announcement was that it was for nursing homes. Obviously, there were some subsequent announcements last week that extend mandates to a much broader range of healthcare providers. We have not seen any additional information on that either, but our understanding is that the mandates that were announced last week, once we see the rules that come forward on those, will apply to a much broader range of healthcare providers.
Yeah, thank you. And I mean, I realize that we're just in the world of hypothecation, which is actually a great word, far too little used. So a number of the governors have pushed back pretty strongly on the employer mandate side. Are you aware of any particular pushback by anybody about the nursing home thing? Just the fact, I mean, we have a testifier who's an expressed concern, but it seems like the employer mandate kind of hit a DEFCON red pushback. I know I signed a letter that was expressing concern about that. But do you know anything about that part at all?
Mr. Chair, I would say we have gotten some questions from facilities that are going to be subject to the mandate. Yeah. You know, long-term care facilities are really stretched right now, and staffing has been a concern. I mean, workforce in long-term care has been a concern for many, many years. That's a chronic challenge. We have heard from some facilities that they are worried that they may have some staff who will choose to resign rather than be vaccinated. I don't have a number on that. I would say we've heard just from a few facilities and through the long-term care associations who we are in very regular touch with. They have heard from a few of their members that they are concerned about the potential loss of staff. You know, for nursing homes right now, around 2/3 of staff are fully vaccinated in Minnesota. So we're right at or a little bit above the national average. For smaller facilities, I think they do have some concerns that if even a few people were to resign as a result of this, or as a result of kind of the cumulative effects of some of the challenges that they face, that would be a real problem for them. And we did, through Commissioner Malcolm, send a letter recently to the Secretary of Health and Human Services and to the CMS administrator, just raising that concern that we've heard around the impact on staffing and asking that they provide federal supports as readily as they can for facilities that might be having some staffing challenges, and that they look at any regulatory flexibility that may be available on the federal level to help for facilities in those areas of concern.
Thanks. And you don't know anything about what is the mandate, you have to get it, or are there religious exemptions? You don't know anything about that. All right, that's fine. Senator Benson, I bet you know something. So.
Thank you. And the federal mandate is a whole other level. But Ms. Roderick, I was really grateful that you raised staffing concerns. So is the department tracking any information on how short-staffed we are, how many shifts are not filled, nurses versus CNA versus other levels of staff? So I have a number of concerns. First of all, this mandate will, when people leave, CNAs in particular, some of the dietary folks, when they leave, there are plenty of other jobs for them to find. And this is going to fundamentally disrupt our healthcare pipeline. And so what's the plan for short staffing now? And how are we going to solve a disrupted pipeline if we don't get some relief for folks?
Thanks, Ms. Roderick.
Yeah, Mr. Chair and Senator Benson, we are working on ways to gather that information. Unlike with some of the hospital capacity data that we have, which I know many of you have seen, where we track hospital capacity on a daily basis, we don't have a mechanism like that for long-term care, but we are working with our partners at the Long-Term Care Association and with others to develop a survey or a data collection tool that we can use to get that information from both skilled nursing and assisted living providers. So it would ask them questions like how many of their shifts are going unfilled right now? To what extent do they have staff who are, working doubles, consistently working overtime, have not had a day off? To what extent are they limiting admissions to the facility due to staffing, which we know is happening in some cases. So we are working on getting that information so we can really understand who is getting to that, real red alert level and might need help. Part of the reason why we wrote the letter to HHS and CMS was to really make sure that they know that we have those concerns. We're doing everything we can to encourage vaccination. We think it is very important for long-term care staff and residents to be vaccinated. We continue to encourage that in every way we can, but we know that that concern is out there, and we wanted to make sure that we were raising it for them, and that they are thinking about what are the ways that they are ready to help if a facility suddenly loses staff and might be facing the prospect of closing or of transferring residents. Are there ways that there could be more flexibility around notification requirements, around staffing ratios, around other things in a way that doesn't risk resident care, but that gives a little more flexibility to facilities? So we're working on pulling together data to help us answer those questions and trying to encourage our federal partners to act where they can.
Senator Benson.
And Mr. Chair, and I don't know if this is Mr. Pollack or Ms. Redrick. So there are times that a facility has to close for a number of reasons. So there are procedures in place. Are we looking at any facilities that are so short-staffed that it would be prudent for them to make a plan to transfer patients?
Mr. Pollack, maybe? Put you on the spot.
Okay, well, thanks, Mr. Chair. Actually, that scenario is one that we've talked about with the providers, and I want to give Assistant Commissioner Rydrick credit and MDH credit. There have been extensive conversations on these topics with the provider associations to consider what planning needs to happen, what data needs to happen. Certainly in a closure scenario, we would be very concerned with resident safety. You have transfer trauma, and we would want to work really closely with the ombudsman, make sure that we could find something as close as possible that's an appropriate alternative. I think the only other point I wanted to make, just sort of from a DHS and funding side, is in addition to federal vaccine mandates, there is also new federal funding that we've just heard about. It's about $25 billion nationally. I don't have a Minnesota number, and both nursing homes and assisted living are included in the eligible provider recipients of those federal dollars. And then we would also obviously and have been working very closely with providers to make sure that the cost-based reimbursement system on the Medicaid side is reflecting these higher costs, the labor shortages, everything that you've already identified.
Very good. Senator Benson.
Nothing further. Thank you, Mr. Chair.
Okay, well, let's move to our testifier, Mr. Devine. Are you here? You've had quite a thing to listen to today. If we've covered a lot of ground. So at this point, you're our favorite testifier because you're the last one. But please take the time you need to tell us what's on your mind. Are you there?
I believe Mr. Devine may have left the Zoom. I did see him join earlier, but I don't see him on now. And I see Senator Udke, he's Senator Udke's constituent, so perhaps Senator Udke may have the ability to
I'm sorry
relate his
about
concerns.
that, Paul. Yeah, Senator Udke.
Yeah, thank you, Mr. Chair. And if Mr. Devine is not there, I did see him on earlier too, but and what he was going to cover, I've got some of that data right here in it.
Yeah, please.
To be a board member of our local nursing home. He's also he's a retired county commissioner who served a number of terms and a retired state trooper. So he's been a very active guy, still remains very active in these things. It would have been good to hear from, but part of it is we just got through hearing some of the data that is coming from the state. But I don't believe that reflects what we really see in a lot of our rural communities. As an example, our local nursing home, about 45% of the employees are not vaccinated. And a large number of those are not going to do it no matter what. We have a nursing home that's at about half capacity now, only because that's all the employees they can get. they've got a waiting list of people wanting to move in to become residents. They can't find the staff to do it. That's where the problem lies, is if this federal mandate moves forward, we're going to see a lot of these facilities get shuttered. And who's going to go? And that would be my question to DHS and all of those involved. I know it's a state and a federal issue, but who's going to go to the nursing home and tell them that, okay, you got to move somebody's grandma or somebody's grandpa out because we can't serve them anymore. And then it was talked about, the plan of moving these people, but I don't believe anybody's got excess staff just standing at the door waiting to go to work. So we're all in the same predicament. We don't have options like that to even move residents from one facility to the other. The one thing, and I'll add one piece on top of that when we talk about how serious this would be if there was a restriction of payment based on Medicare and Medicaid. My local nursing home, 72% of their income comes through Medicare and Medicaid reimbursements. I want to know, what are we doing as a State Department at this point? I know there's a ton of unknowns, but what are we doing to be proactive and being in contact with the federal government and expressing these dire concerns? We don't have options to play this game, and we've got to be going with some pushback. I know that Senator Adler mentioned the letter that he signed on to. A number of us did here a couple of weeks ago, expressing our concerns to the president. And I would like to see and I hope the agency is doing the same thing here in the state, because this is a disaster coming down the road at us. And that's, I guess, rather than repeat anything, it's kind of where I'll leave it. But we are concerned out here. And when you go to those that run the nursing homes, they are concerned because of the unknown. In any business, that's the worst position you can be in, because you hear what's coming, but you don't know any of the details, and it could be what wipes you out. So with that, Mr. Chair, I'll pass it back to you.
Thanks. And maybe that's just a setup for what I wanted to ask Mr. Pollock anyway. So somebody, but I've been told, at least anecdotally, that many nursing homes are not accepting new residents these days because of staffing concerns. Do you know that to be true, Mr. Pollock or Ms. Rydrick, whichever one? Mr. Pollock.
Okay. Yeah, Mr. Chair, I think the issue of staffing was a pre-pandemic one. And obviously we've been trying to do a lot as a state to improve the workforce. And the vaccine issue is one that complicates things. It's one that we should work through I'm going to kind of repeat something that our provider partners have said, really like a three sort of phase approach. We need to be thinking about the emergency situation that we're in, really the next month, maybe what Senator Key is referring to, of a large percentage in certain counties being unvaccinated. And, we need to think about remedies for that. And then a really, sort of medium term over the next year, how do we get out of COVID? How do we get out of this constant crisis situation? But then also the long term, what do the next couple of years look like? How do we bring a huge volume of workers into the field so that we have these career pathways for folks? So I'll let Assistant Commissioner Rydrick speak to this as well. I know this is really foremost in her mind.
Yeah, Ms. Rydrick.
Yeah, thanks, Mr. Chair, and thanks, Assistant Commissioner Pollock, for kicking it over to me. I would echo exactly what he said, and those are the conversations that we've been having with providers. What are the things we can do now, but what are the things that we can do in the longer term to address what has been a really chronic challenge for long-term care, especially with some of the direct care providers, direct service providers, and CNAs. To your question about whether facilities are limiting admissions right now, my understanding is that yes, some are. We have information indirectly through some surveys that the Long-Term Care Imperative has done of their members. And through that mechanism, we have heard that there are facilities that are limiting admission based on staffing right now.
Thanks. And I wasn't intending to blame the vaccine thing on the short staff. We've been discussing this as long as I've been in this legislature. And I'm just trying to decide, Mr. Pollack, I just have to push back a little bit. And you know, some people just don't want to get a vaccine. They have the right to not get one. And so as we talk about that being a problem, people still have freedom to exercise that, and just have to mention that to you. And so that's as far as I plan to go. But it's a challenge, and I want to appreciate the Department of Health for reminding the feds that we can't take much more pressure on our system, and that people will come to harm, and that in the greater Minnesota, I think Senator Utke was pretty eloquent, and perhaps what's his name, Mr. Devine wants to send us a letter. We can get that out to the committee. But I certainly want to, you know, as this moves on, we do want to know the impact. And I was wishing there'd be some more information, which nobody has, about what is the impact, what exemptions are available for people who are just have any number of reasons not to avail themselves of that treatment. And what will happen to these places? What's the amount of penalty going to be in an already very challenged system? The only thing good I can think of is the unemployment's going to run out pretty soon. So people will get back to work, and you know, that at least the workforce, a lot of the concerns are gone about people. We just need to get those folks back to work. Anyway, I don't see any more hands. I want to thank everybody for their effort today. We covered a lot of stuff in 2.5 hours. I'm kind of glad we only went a half hour over my particular goal. But so just to recap, on this competency restoration thing, we have got to do something to get it from being just a mess and a risk, a public safety risk, to serving the individuals while protecting the public. We just have to get that sorted out. And we're going to have to talk about the elderly waiver bit. We're going to have some kind of meeting with whoever wants to come to it about childcare, and there'll be another meeting following up about this day services and what's the HIPAA duty people have, and what about how do you serve individuals that have that's their only place they really can thrive at. And then certainly we'll have to follow up on this nursing home thing. But and I want to wish our two departing staff the best for their extremely good service. So we'll keep you in touch. Any follow-up you want to do, my email and phone are open. So seeing no hands, we're adjourned. Thank you very much.